1872 by Mautner in Innsbruck. And it's one of the types of retinal degeneration that should be instantly recognizable to most clinical ophthalmologists because it has quite an obvious appearance at the back of the eye. This, of course, is a great advantage because it enables us to identify a potential gene to look for from the very beginning of seeing these patients, and also it's X-linked, which gives clues to its inheritance and genetic testing. The appearance of choroideremia can be shown in this picture, where on the left-hand side you can see pale, atrophic appearances of the retina. The name choroideremia, a sort of wasting and disappearance of the choroid. By comparison, on the right is a picture of the normal retina showing the healthy optic disc, the fovea, and the choroid. The gene, the defect in the gene that causes choroideremia is the REP1 gene. This gene is 1.9 kilobases in size, 1,900 base pairs. And of course, for a gene replacement approach, this is an ideal size to fit into an adeno-associated viral vector with plenty of space for other components. It is X-linked and it's present on the X chromosome. Almost all of the cases of choroideremia we know about to date are due to null mutations in the REP1 gene. In other words, it's a deficiency of REP1 rather than abnormal REP1 protein, and the fact that it's a deficiency, again, is something that helps us a lot in developing a gene therapy treatment, because we aim to replace the gene, which may be technically easier than to knock down a gene which is causing problems. So, in this particular disease, the mechanism of choroideremia has been elucidated by my good colleague and collaborator with this trial, Miguel Ceguera, and it's due to deficiency of a protein interaction within cells known as prenylation. The REP1 protein binds to RAB27A, which is a protein involved in adding lipid groups or prenyl groups to other cells, other structures within the cell, particularly melanosomes. This prenylation allows these other cell organelles to be trafficked and moved around in the cell via microtubular transport. So it's a defect of trafficking caused by the absence of REP1. We really don't know exactly what the mechanism is, why this causes cell death of the retinal pigment epithelium. But we do know that the REP1 protein is expressed throughout the body, and for some reason it's only really causing a clinical effect in the eye. So, when setting up a clinical trial, one of the most important things that we're always asked is, how are you going to define your start point or your end point? In other words, you can have the most brilliant idea in the world and a fantastic treatment, but unless you can convince an ethics committee that in your trial you will find the answer to your question, they will not allow you to go ahead. With inherited retinal degenerations, we have the inherent problem that it is a very slowly progressive disease. This example is a patient of mine who's 62 years old. His vision is still 6/12 in both eyes, so he can read a long way down the eye chart. And you can see the degree of degeneration that's taken place over 62 years. If we were to treat one eye, how long would we need to wait before we saw a treatment effect? Well, one of the good things about choroideremia is that it has a very peculiar pattern when we look at autofluorescence. Here, you can see in this autofluorescence imaging that despite the sort of amorphous appearance of the retina looking at it through a normal photograph, when we look at the fluorescence pattern, we can see very distinct and precise islands of surviving retinal pigment epithelium. So, this gives us something clear and anatomical by which we can assess any changes in the patient after a gene therapy treatment. Andrew Webster and myself at Moorfields Eye Hospital went through many images of patients with choroideremia to look at the autofluorescence pattern. And I'm showing you here some pictures from 2004 on the top left, right eye and left eye, and 2008 in the bottom left again, right eye and left eye from the same patient. When you look at these pictures initially, they look very similar. But if you actually draw around the pictures very carefully and measure the area, you can have a figure which is a numerical value of the amount of surviving tissue. And what we found is that there's a fairly consistent rate of degeneration in both eyes, at approximately a loss of 10% area per year. Now, we've only assessed patients in the later stage of the disease, the time at which we'd wish to put them into a clinical trial, but this appears to be fairly consistent. And most importantly, it's symmetrical between the two eyes. So if we intervene on one eye, we can then use the other eye as a control. So rather than waiting 62 years to see if the disease develops, as in this patient, we may now be able to look at the autofluorescence pattern and find out in a very short period whether any treatment has been successful in slowing the degeneration, we estimate within 2 years. This is an example where our contact with patients is essential, because we spend a great deal of time looking at patients with this disease, assessing, analysing, and I know that when some of you come into our clinics, you wonder why there's all the waiting around and pictures and scans, but it really is the way that you're helping us help you in finding out about the mechanism of the disease in order to think about clinical trials. So another test we use is microperimetry. This is a test where a patient will look at a spot of light in a machine, and spots of light will be shone on the retina around the centre. It's a bit like the big field test that you would do for glaucoma screening or the Goldman field test. But microperimetry is a little bit different because there is a camera, an infrared camera, which is tracking the movements of the eye. So the computer knows exactly where the spot of light is being applied at the time the patient presses the button. And in our trial, we're using this microperimetry. We get the patients to do the test several times before they're actually enrolled into the trial to make sure they're familiar with it. But because these patients have very, very good visual acuity, they're able to maintain good fixation and do the test very reliably, which maps reasonably well to the areas of surviving fluorescence that they have on the autofluorescence imaging. The other tool we have in our clinic, of course, is OCT, and the OCT shows a very precise area of retina that's surviving. You can see in this patient the fovea, which actually looks relatively well preserved, whereas I've shown here with a black line, an arrow pointing to the edge of the retinal pigment epithelium, and to the right of that, the retina is degenerating, and you can see underneath, the choroid is degenerating as well, marked by the yellow arrows. So, an important scientific question in developing any gene therapy clinical trial or treatment is to consider which cell type are we going to target. In the case of choroideremia, we have atrophy of the choroid and the retinal pigment epithelium and the photoreceptors. Do we need the vector to infect all of those layers or just one? And again, the clinical observations are very helpful to us as clinicians to try and identify the clinical mechanisms of the disease, which helps in developing the treatment. So what I've shown in this picture here is that it does appear on the scans that the retinal pigment epithelium degeneration is going ahead of the choroidal degeneration. In other words, it may be that the choroid is degenerating secondarily to the loss of the retinal pigment epithelium. So what evidence do we have of that? This is another patient of mine. She is a carrier of the condition, and you can see she's got good vision. If you look in the periphery, you can see some speckling of the retinal pigment epithelium. And if we look at that in more detail, this is in the retinal periphery, we can see clumping of the retinal pigment epithelium, characteristic of being a carrier of choroideremia. Now, because the X chromosome is inactivated randomly between the retinal pigment epithelium and the choroid, we would expect to find some areas of the choroid where the X chromosome has been inactivated, leaving her with a localized area of choroideremia if the choroid was primarily affected in the disease. And to date, please correct me if I'm wrong, any other experts here, but I have not observed that in any of these patients to have choroidal abnormalities as well as abnormalities in the retinal pigment epithelium. This is another patient of mine. He's a young man from the Netherlands. He has a fairly advanced choroideremia, you can see by the appearance of his retina. But the right eye has got good vision, left eye the vision is quite poor, and there's a loss of the tissue, as you can see in the centre of the left eye. And here you can see on the autofluorescence, he's got on the left side of the screen an island of surviving autofluorescence, whereas that's deficient on the left. This shows his OCT scan, and you can see underneath the retina, just here on his left eye, he's got this area of scar tissue. This is a choroidal new vessel, blood vessels which grow through from the choroid in a very similar way to what happens in age-related macular degeneration. So here is a gentleman with choroideremia who unfortunately has suffered an event of blood vessel growth from the choroid under his fovea, which has led to a sudden loss of vision. So again, we have evidence that the choroid itself is capable of regenerating and repairing itself despite the deficiency of the REP1 gene. And finally, here is another patient. You can see the typical appearance of choroideremia with the atrophic central areas of the retina, the pallor, and the clumping peripherally of the retinal pigment epithelium. The characteristic signs of autofluorescence showing these small, discrete, but very clearly identifiable islands of surviving tissue. And the OCT scan confirming choroidal atrophy and thinning of the retina. This patient, however, has got a mutation in RPE65. He's one of these patients in this recently described condition from Peter Humphrey's group, who has a phenotype looking very similar to choroideremia due to a genetic mutation in a gene that is expressed purely in the retinal pigment epithelium. So we know from the observations from these patients that it is possible to have a gene defect which we know to be in the RPE, but which manifests itself in a clinical appearance very similar to choroideremia. So from the observations we have so far clinically, we believe that the right layer to target would be the retinal pigment epithelium. And we don't know for sure, but the evidence suggests that we do not need to target the choroid in this disease, which is of course very helpful because AAV vectors are not particularly effective at targeting vascular tissues. The other question relates to whether or not we need to target the photoreceptors. Again, this is a very difficult question to answer because it may be that the photoreceptors are degenerating but at a slower rate than the retinal pigment epithelium. But here we have work which we do in the mouse. Again, this is work that I've done in collaboration with Miguel Seabra, where we knocked out the choroideremia gene just specifically in the photoreceptors in the mouse, and we found a very slow retinal degeneration and also a reduction in the ERG, electroretinogram. We also observed in the mouse anatomical signs of cell death by accumulation of subretinal macrophages in the presence of the photoreceptor knockout. So some evidence in the mouse that the photoreceptors need the REP1 for survival. From human perspective, this is a